So, good morning. Today we will have a longest discussion. Dr. Nitesh Pradhan, who is third year JR at MR Bangalore Hospital, present the case. And with me today will be Professor Ditendra Kumar Sarkar. He is a professor, head of professor of surgery and in charge of breast clinic services at IPG and SSK Hospital. We will moderate this session with me. Dr. Nitesh, you can share your screen and present. Wait at the end of history presentation, let us discuss and then proceed to the examination and subsequent discussion.
Good morning, respected teachers. A 35-year gentleman from Kolkata, West Bengal, of Hindu religion, businessman by profession, presented with a lump in the upper abdomen since 2 months. The patient was relatively asymptomatic 3 months back. Then he developed complaint of upper abdominal pain, which lasted for 10 days and was sudden in onset, severe, continuous in nature, was relieved on taking medication and exaggerated on lying down. Radiating front to back and associated with multiple episodes of nausea and vomiting, for which he was hospitalized for 10 days and was resolved on conservative management. Patient noticed a lump in upper abdomen 2 months back, which was insidious in onset, gradually increasing in size for duration one month, and has static in size for last 1 month, and is around 8 cross 8 centimeter of present size, associated with intermittent dull aching pain, which is relieved on medication. There is no history of fever, hematemesis, melena, significant weight loss, altered bowel habit, and vomiting. No history of any abdominal trauma. No history of LAS discoloration of sclera. No history of any other swelling. There is no history of any other systemic symptoms. Past history. There is no history of any medical illness and surgical intervention in the past. No history of comorbidity like diabetes, hypertension, thyroid dysfunction, or COPD. No histories of any allergies. Personal history. Patient is married, nuclear family comprising of spouse, one son, all alive and well. Alcohol, there is a history of alcohol consumption for 16 years, drinking approximately 180 ml of alcohol daily, and abstinence from last 3 months. Diet, Bengali mixed diet, bowel and bladder habit are unaltered. Family history, parents are alive. He has 1 brother and 2 sisters, all alive and well. Summary of the history: a 35-year gentleman from Kolkata, West Bengal, presented with a complaint of a lump of approximately 8 cross 8 centimeters, the epigastric region of abdomen since last 2 months. Patient has history of upper abdominal pain, which lasted for 10 days and was sudden in onset, severe, continuous in nature, and radiating from front to back, associated with multiple episodes of nausea and vomiting from last 3 months. Also, there is a history of alcohol consumption since 16 years.
Okay. I think you have done a good job by taking the history which is relevant. If you know that the case is likely to be a pseudocyst of the pancreas. And having said that, what are the other histories that you'd like to include once you have an epigastric mass, a patient presenting with an epigastric mass?
Patient presenting with epigastric mass, sir, we have to rule out the other involvement of origin, like sir, the pathology from the stomach, transverse colon, pancreas, and left lobe of the liver, and sir, retroperitoneal pathologies.
Okay, so you are going to take histories related to that, and one very important history that you are going to take if the patient complains with an epigastric mass is whether the patient has got any swelling in the testis or not.
Yes, sir. Yes, sir. Testicular.
So that is a very important thing. So, and the next important question that you may be asked is, what histories you have taken to exclude a background of chronic pancreatitis?
Sir, we'll ask the history of exocrine and endocrine insufficiency,
yeah,
steatorrhea, patient may present with chronic persistent pain and sir, diabetes.
Diabetes and steatorrhea history. Now, why do you think it is important to differentiate between an epigastric mass following an episode of acute pancreatitis and an epigastric mass on the background of chronic pancreatitis? Why do you think it's relevant? Why this history is very important?
Sir, in background of chronic pancreatitis, the the management part will be changed, sir.
Exactly. Okay. So can you tell us how did the mass progressed over the last, this 8 into 8 centimeter mass over the last 2 months? You told that there is a mass which is 8 to 8 centimeter, but how had that been progressing over the last 2 months? Has it been increasing, static, or decreasing?
Sir, sir, 1 month, sir, there is the mass was static in size, sir.
And before that, it was bigger in size.
Yes, sir.
It came down in 4 months, 4 weeks time, and then the next 4 weeks, it is persisting at the same level.
Yes, sir.
Okay. You did tell that there is no history of hematemesis in such a patient. What do you think are possible causes of hematemesis in such a patient with the background of an epigastric lump?
Sir, with the background of epigastric lump, sir, in this case, sir, there might be there is history of acute pancreatitis that may lead to formation of pseudocyst, and the complication of pseudocyst like splenic vein thrombosis and pseudoaneurysm of arteries, and that condition is Haemosuccus pancreaticus.
Very good. One of the conditions can be Haemosuccus pancreaticus. Anything else that can happen? You told about splenic vein thrombosis. That can also lead to
portal hypertension.
Lead to portal hypertension. And third, of course, is you are excluding a gastric mass, isn't it?
Yes.
So once you suspect that there is a mass in the epigastrium and you have taken the history of hematemesis, you must be able to tell that there are 3 factors. One is a gastric condition, number 2 is Haemosuccus pancreaticus, and number 3 is portal hypertension secondary to splenic vein thrombosis, and all 3 can present as an hematemesis.
Yes.
Okay. You told that the patient does not give any history of jaundice. What are the reasons why such a patient can present also with a jaundice?
Sir, pseudocyst can lead to, sir, pressure effect on this distal CBD that may lead to obstructive jaundice. And also, sir, if it is pseudocyst with chronic pancreatitis, can lead to, sir, obstructive jaundice.
Very good. And the fact that you also told that the patient is suffering from has a substance abuse history of alcohol which goes back to a long distance, you can also suspect associated ALD in such patients, isn't it?
Yes.
Alcoholic liver disease is also a suspicion in such a patient.
Yes.
Okay. And also if the patient develops portal hypertension, that also can lead to development of jaundice. As also that the fact that the patient has got a left lobe mass can also lead to a jaundice.
Yes.
So you understand, once you are stating one particular statement, you must be able to analyze what are the reasons why you have stated this. Okay. Okay. Sir, any questions? Or
yes, actually, the way he started the history, I have some observation. He said lump for 2 months, and then he started describing the pain for 3 months. So I would have preferred that is a very close succession. So in the Chipflin event, the history of pain should come. Pain in the abdomen for last 3 months, and then lump for 2 months. So that is very close succession. So you have started with the history of the pain only. So in that case, the history is important because the pain started 3 months back, and then he was treated and pain relieved. And sometimes when the patient develops a complication like pseudocyst, patient may again have a pain being continued. Yes. So start the history like that. The history of pain and then followed by the lump. And otherwise, the other part you touched was almost all right. And then another thing Dr. Sarkar has pointed out, this pseudocyst may form on the background of chronic pancreatitis. So in the history, you have to specifically ask in the past history whether he has got similar episodes of pain, because he is alcoholic for 16 years, which is a background of chronic pancreatitis. And patient with chronic pancreatitis has higher incidence of pancreatic neoplastic mass also. So you have to consider that part. Okay, otherwise history was all right. So you can pass on to examination.
General physical examination. After proper informed consent, the patient was examined in supine position and well-lit room. He is alert, oriented to time, place, person. His build is average, nutrition average, BMI of 18.6, Karnofsky score is 80. There is no pallor, icterus, clubbing, cyanosis, edema, and lymphadenopathy. Vital signs are essentially normal. Abdominal examination and inspection. The abdomen is not distended, but there is a fullness in the epigastric region. Umbilicus is central in position and inverted. No scar and pigmentation over or the dilated vein noted. No normal movement with respiration is noted. No obvious swelling noted over abdomen and hernial sites, even on coughing. External gelatinias appears normal. On palpation, swelling is palpable in epigastric and umbilical region. This of size 8 cross 7 centimeter, globular in shape, smooth surface with tense cystic consistency. Lump is intra-abdominal, which is confirmed by a leg raising and head raising test. Swelling is slightly moving up and down with respiration, non-mobile, non-tender. Temperature over the swelling is normal. There is no muscle guarding. Liver, spleen, kidney not palpable. No other lump is palpable. On percussion, general tympanic node over the abdomen and dull node over the lump. No signs of ascites. Upper border of liver dullness noted at fifth intercostal space. In mid-clavicular line, liver span is 12 cm. Auscultation, normal peristaltic sound heard. Other systemic examinations are essentially normal. Summary of the case: 35-year gentleman from Kolkata, West Bengal, presented with complaint of lump approximately 8 centimeter in the epigastric and epigastric region of the abdomen since last 2 months. Patient has a history of upper abdominal pain 3 months back, which lasted for 10 days and was sudden in onset, severe, continuous in nature, radiating from the front to back, associated with multiple episodes of nausea and vomiting. Also, history of alcohol consumption since 16 years. General physical examination and vital signs are essentially normal. Abdominal examination reveals smooth, globular, non-mobile, tense cystic inconsistency, intra-abdominal lump in the epigastric and the umbilical region measuring approximately 8 cross 7 centimeter. Systemic examination was also normal. My provisional diagnosis: 35-year gentleman with lump in the epigastric region. Aforementioned history and the examination is most probably suffering from pseudocyst of pancreas.
Okay. Now, the first and the foremost thing which Dr. Saha and myself has been telling to all our students over decades is that in abdomen, unless you have a definite proof, do not tell abdominal swellings to be cystic. Because to prove it is cystic, you need to have certain tests being done. So tell it firm, because actually if there is a mass, if there is a muscle, it always becomes a completely firm swelling. However, there are certain liver swellings which bulge out. They appear to be cystic. Then you have to demonstrate hydrated thrill by placing 3 fingers, percussing and feeling by the 2 fingers. Those things has to come. Or else, to tell that some swelling is cystic, you have to show at least thrill, or you have to show fluctuation, or else you cannot tell it to be cystic. It's better to qualify it as a firm swelling. Okay.
And then temperature of the swelling is a temperature of the abdominal wall, which will not be reflected.
Okay, so this, I think, make it a point. Now, try to understand, either a pseudocyst is hugely bulging, then it is displacing in between the colon and the stomach to come outside. Then only it becomes cystic. Okay, point number 1. Point number 2, I would have enjoyed if you have given a bit more detailing of the lump. What is the upper extent of the lump? What is the lower extent of the lump? What about the gap between the costal arch and the upper extent of the lump. So can you elaborate on that? Because that has got a major impact in your diagnosis.
The lump is in the epigastric and umbilical. Now try to give a clear idea. Umbilical is a big area. Even it is going below the umbilicus. So how far the lump is extending below, up, lateral, medial?
Sir,
And then give the points to differentiate this lump from a liver lump also.
Sir, upper border of the lump is sir, clearly seen, sir.
Clearly felt. Clearly felt.
Yes, sir. Yes, sir. And sir,
What is the gap between the costal arch and the upper extent of the lump?
sir, around 1 centimeter, sir.
So you can insinuate your fingers between the upper edge of the lump and the costal arch. That's the point we are looking at. Because if you are unable to reach the upper pole, that actually go in a different direction. Okay? Are you able to see the medial and the lateral extents?
Either side.
Either side. Is it well defined or it is ill defined?
So you see, if you have a lump in the epigastric and the umbilical region, you see it's not going to the lumbar. So you should get the lateral margin of the lump. A classic pseudocyst often you can feel all around the lump. What do you find in this case?
Sir, lateral and medial margin, sir. Border, sir, smooth, sir.
Smooth. But are they well defined or they are ill defined?
Sir, well defined.
Okay. Now, see, I give you a bit of advice. When you are presenting in front of the examiner, go down to your third year basics in MBBS. You tell that there is a lump. The upper extent of the lump is approximately 2 centimeters below the costal arch. I can insinuate my fingers. The upper, the edge of the lump is well defined. Medially also is well defined. Laterally also is well defined. The inferior extent of the lump is approximately 3 centimeters below the umbilicus in supine position, and I am able to ascertain the lower edge of the lump as well. The surface of the lump appears to be smooth. The consistency, as you told, is firm. But if you find that there are evidence of hardness, then it becomes a variegated consistency. Okay.
Yes.
Now, is the lump mobile from side to side?
No, sir.
Is the lump moving up and down with respiration?
No.
Is the lump pulsatile?
No, sir.
Can a lump situated in this area be pulsatile in nature?
Yes, sir.
How would you ascertain pulsatility in such a big lump? You can show us in front of the camera with your fingers.
Sir, on inspection, sir, we have to see.
What do you do with your finger?
Sir, we have to place sir, middle and index finger, both the hand vertically over the lump, sir, and we can see sir, the finger will, sir, lift up if there is a pulsation.
In a pseudocyst, can you expect this pulsation to come, and what type of pulsation it will be?
Sir, it will be, sir, a transmitted pulsation.
How to differentiate?
Sir, in transmitted pulsation, there is raise of finger, and sir, in pulse, sir, if it arises from the aorta, then like aortic aneurysm, then there is a separation of separation of both fingers of both the hands, sir.
Yes, very good. So you can do it like this. Now the other question that you must remember is that why are you placing it vertical? Because I am placing my fingers along or parallel to the axis of the named vessel here. So you can place the fingers like this, or you can hold it like this and try to see whether the movement is like this or the movement is like this. Now, if you have a central upper abdominal lump, make it mandatory that you must comment about pulsatility, because one of the differentials can be an aneurysmal swelling. Okay. Yes. At postgraduate level, that is something which is expected from you. Okay. Now, what about the percussion note of this swelling?
Sir, percussion note, sir, Sir, it will be dull, sir.
No, what do you find in this patient?
Sir,
What do
dull.
you find in this patient?
Sir, dull note, sir, over the swelling.
And what about the percussion node surrounding the swelling?
Surrounding the swelling, sir, sir, it is tympanic, sir.
Now, have you been able to ascertain a percussion node which is tympanic in between the upper edge of the lump and the costal arch?
Sir, it is difficult, sir.
No, you told that there is a gap of around 1 to 2 centimeter because upper extent of the lump and then the costal arch, and you are able to insinuate your finger. Now, is this dullness continuous with the dullness of the so-called costal arch and the intercostal space, or there is a gap in between the two?
So you might have stomach in this intervening area.
Yes, sir.
So stomach is also in front of the cyst.
Yes, sir.
But as the cyst is bulging, it can compress the stomach, and you may not appreciate the tympanic note of the stomach over the swelling itself. But when the swelling is not there, can you expect some change in note?
Sir, sorry.
You mean at the upper border to the costal margin?
Sir, if swelling is not there, sir,
What do you find in this patient? You have not probably noticed it, but point is, if you have a gap in this area, you might find that area being resonant, because that is important. If the dullness is continuous, then it is again difficult to differentiate between the liver swelling and another swelling here.
Okay, so make it a very important thing to percuss. And there is another sign, if you remember, which is called Tinel sign. Do you remember that there used to be something called Tinel sign, which is particularly when there is a mesenteric cyst, there is a perimesenteric cyst area of resonance and the central area becomes dull. So mapping the percussion dullness is very important in such a swelling. Okay.
Yes.
Okay. So have you examined the external genitalia and the testes and excluded any possibility of a testicular mass?
Yes, sir, I've examined, sir. Sir, there's no scrot. Sir, the genitalia appears normal, sir. There's no scrotal swelling.
Okay.
Sir.
Have you examined the supraclavicular fossa?
Sir, yes. So there is no lymphadenopathy.
There is no lymphadenopathy. So, sir, any other clinical
in abdominal examination, you must make a heading of PR examination. You cannot skip that. Yes. You have not mentioned about PR examination not done or whatever. You should at least in the exam say that you are doing a PR examination also. Yes. Okay. Otherwise, yes, we have discussed. You can start with the justification of diagnosis and subsequent management. History part you have discussed. Okay, fine.
You can go to.
Why do you say?
What is your diagnosis?
Sir, sir, my diagnosis: 35-year gentleman with lump in the epigastric region with aforementioned history and examination is most probably suffering from the pseudocyst of pancreas.
Following?
Following setting of acute pancreatitis.
So pseudocyst of the pancreas. What are the points in favor of pseudocyst of pancreas?
Sir, for pseudocyst of pancreas, sir, there is from history, sir, there is history of pain abdomen, which is acute in onset, sudden, and sir, that is 3 months. Duration is 3 months back, and sir.
Now you can summarize. No? At the end, you can say probably he was having an episode of acute pancreatitis, which required hospitalization, yes. And then following that, he is noticing this lump.
Yes, sir.
So that is one point in favor.
Yes, sir.
And on examination, you find what to say is a pseudocyst.
Sir, on examination, sir, so there is a firm swelling over the gastric and umbilical region. Sir, it is not non-mobile, and sir, dull note on percussion.
Okay, so you think it to be a pseudocyst of the pancreas. Okay, is it on the Background of an acute pseudocyst or it's a chronic pseudocyst?
Sir, it is from the acute pancreatitis, sir.
So you think it is likely to be an acute onset pseudocyst of pancreas? Okay.
Yes.
What are your differentials?
Sir, my differential would be, for pseudocyst of pancreas as per the history and examination. Sir, there may be a cystic neoplasm of the pancreas.
Why would you like to bring in cystic neoplasm of pancreas as your second differential?
On the background of alcohol, on the background of this pain, can it be a pseudocyst of other etiology? One is acute pancreatitis. Anything else?
Chronic pancreatitis.
Yes. Pseudocyst as a complication of chronic pancreatitis.
Yes.
Now what else? Don't bring a diagnosis which is not very closer to the clinical presentation. Okay. A cyst adenoma usually does not present with acute pancreatitis and then comes with a lump. A cyst adenoma gradually increases in size with vague symptoms.
What is happening is you are getting heavily biased towards the cystic swelling of pancreas. Therefore, I mean, in our clinical practice, looking and palpating a lump and giving a diagnosis of cystic neoplasm of pancreas is very tough because it's not a very common entity that we face every time. Okay. So I would not prefer, you can tell it's a mass arising from the body of pancreas. That's accepted. But to stamp it as a cystic neoplasm of pancreas, because it's basically an entity which comprises of some pathological factors, some biochemical factors, to stamp it as a cystic neoplasm. So you can tell it's a mass arising from the body of the pancreas, we will accept it. Okay, but not cystic neoplasm of pancreas. Okay, so apart from a mass arising from the pancreas, of which you told pseudocyst 1, and number 2, a mass arising from the body of pancreas, what other things you would like to bring as your differential?
Hydrate cyst from the left lobe of the liver, sir.
You have differential is not liver. So don't bring liver as a third diagnosis.
Exactly.
Because clinically you said liver is separate. You can insulate your finger. So why being? It can come later on, but there are some other cystic lesion which can come in the pancreas or in this location.
So walled.
I mean, walled of necrosis. That is again a difficult diagnosis if we don't have the details of the acute pancreatitis.
In now, if 2 months, at least 3 months from the attack, it cannot be a walled of necrosis now. It either is a pseudocyst or it's a pancreatic abscess. And in a pancreatic abscess, patient is likely to be extremely toxic. So one I understand is a pseudocyst, acute onset, pseudocyst, chronic onset, mass arising from the body of the pancreas. Anything else?
Any other cystic lesion?
Sir,
in the pancreas or in the retroperitoneum?
So cystic swelling from retroperitoneal.
Okay, you give whatever swelling, if you are unable to tell about cystic swelling, because cystic swelling of the pancreas is a classification, of which one is pseudocyst, second is cystic neoplasm, third will be hydrated cyst arising, degeneration in a malignancy. These are all categories of cystic swelling of the pancreas. So forget about, now suppose if it is not arising from the pancreas, what other conditions?
Sir, from stomach, sir, it can be, sir.
What swelling in the stomach may present with a large mass and minimal symptoms?
Sir, minimal, sir, gastric lymphomas.
Before that? Before lymphoma?
Sir, cysts.
Yes. Stromal tumors. They may present with hematemesis, but may not have hematemesis, just may present with a lump in the epigastrium.
So stomach, it can be a cyst or it can be a lymphoma. Okay. Anything, any other structures do you think which can give rise to such a mass in this area?
Sir, Sir, retroperitoneal, sir, retroperitoneal, sir, there's
Retroperitoneal.
metastatic lymph node, the retroperitoneum, sir, retroperitoneal.
So retroperitoneal mass. So now once we have discussed last day, if it's a retroperitoneal mass, what are your realistic possibilities?
Sir, retroperitoneal mass, patient may not have.
Now, what is the possibility? What can arise in the retroperitoneum? One is
Sir, sir, lymph nodes.
Lymph node mass.
Sir,
Next.
Sir,
by definition, retroperitoneal tumor does not include tumor mass. The lymph node mass. Okay, retroperitoneal tumor has got a separate definition, which is not arising from a defined structure.
Yes, sir. Sir, then aneurysm, sir, aortic aneurysm. Sir, tuberculosis.
Okay. Now let us sum up. Now, number one, if it's a retroperitoneal mass and if you suspect to be a lymph node mass, the possibilities are metastatic lymph node, tuberculosis, or lymphoma. If you think it's a metastatic mass, you need to search the primary sites, of which testis is most important. If you think it to be tuberculosis, then you need to have a good chest auscultation and ask the patient history of contacts. If you suspect to be lymphoma, you must examine other lymph nodes and liver and spleen to exclude lymphoma. So these are all association fibers which must work when you are presenting this, and whether the patient has fever or type B symptoms or not. The next possibility is a retroperitoneal tumor. If it's a retroperitoneal tumor, then you have the possibilities of a lipoma, lipoma or liposarcoma, or what other things which you can think of. Clear? Can it be anything else in this area, epigastrium and the umbilical region?
Sir, transverse colon mass.
Do you expect the transverse colon mass in this particular patient? What are the points in favor? What are the points against?
Sir, there's a history of acute pancreatitis, which is not there in transverse colon mass. Sir.
And such a large mass in transverse colon, what symptom patient would have?
Sir, patient have altered bowel habit. Sir, altered bowel habit. Patient may present with a large bowel obstruction, sir.
Very good. So anything else that you can think of? It can be an omental mass or a mesenteric mass.
Yes, sir. Omental mass, omental cyst.
What are the points looking at this patient clinically? What are the points on examination which is against a mesenteric or a omental mass?
Sir, mesenteric cyst, sir. Sir, it will be, sir. Swelling will be below the umbilicus, sir.
It can be above umbilicus. Why not? Root of the mesenteric goes above the umbilicus also, yes, to the left hypochondriac region. So what is the characteristics?
Tell the root of the mesentery. Okay. And it moves parallel to the axis of the attachment of the mesentery. So in this case, the lump is not mobile, so I don't consider it to be a mass arising from the mesentery. An omental mass has got a free mobility in all axes. In this case, again, it is fixed, so I do not consider it to be an omental mass. I mean, these are very classical points. You just stick to the classical points. Okay.
Yes.
So, sir, we can move to the investigation.
Yes.
What investigations will you do in this particular patient?
Sir, investigations for, sir, first I'll confirm my diagnosis by doing some radiological and blood investigations. Sir, radiological investigation include USG of whole abdomen, CCT whole abdomen.
Wait. You said USG. How USG is helpful? Tell us some points on the background of your diagnosis.
Sir, background of diagnosis, sir. The USG shows cystic swelling and the relation to the pancreas, and sir, it also exclude the associated chronic pancreatitis. pancreatic duct, and sir, if any intraductal calculi.
What else? Don't be confined only to the pancreas. Ultrasound is a very good investigation
sir, it
for
can also,
hepatobiliary system.
yes, sir. It can also diagnose. Sir, it can also show the gallbladder stone, sir. And sir, in the diameter of common bile duct, sir.
You see, we are considering alcoholic pancreatitis and then pseudocyst. It can be called second possibility gallstone pancreatitis. So ultrasound will help us to evaluate the hepatobiliary itself.
Yes, sir.
Then you are thinking of some lymph node mass.
Yes, sir.
Ultrasound can show any lymph node mass in this area.
Yes, sir.
Okay.
Yes.
Now,
so ultrasound is a very good investigation. You should keep in mind what you are like to get in this report.
Now, while you have done this ultrasound, now if I suddenly allow my radiologist to add a Doppler mode, what more information you can get in such a patient? You only told, you told everything. If you now do a Doppler with it.
Sir, Doppler, sir, sir, if there is associated.
What about the vascularity of this mass? Sir, if you think of pseudocyst.
Pseudocyst, sir, hypovascular.
Hypovascular. If it is a tumor,
sir, it will be, sir, hypervascular.
Number one, and number two, you talk of some complications.
Yes, sir. It will tell about the, sir, portal hypertension, portal diameter, sir. Also, if there is associated aneurysm.
Yes.
So hemosarcus pancreaticus can be well delineated if you are doing adding a Doppler to it. Okay.
Yes.
So you have done this. What will be your next investigation?
So the next investigation will be, sir, CECT of the whole abdomen, sir. Sir, in CECT of whole abdomen, we'll see the first, sir, location of the swelling. So then characteristic of the swelling, sir, in pseudocyst.
You tell us what more points. Ultrasound is a good investigation. From ultrasound, what further investigation can be obtained from a good quality CT scan?
Sir,
swelling, cystic or solid is shown by ultrasound, yes, corroborated by CT scan. Anything else which ultrasound was little poor and here you can see it better?
Sir, we can see the characteristic of swelling.
That is one. Second is the background of swelling. Is ultrasound good enough to assess the rest of the pancreas in ductal structure?
Yes, sir. Sir, pancreatic parenchyma, sir, it will be more visualized in the portal venous field, sir. And CCT.
See, again, the most important thing, as sir is suggesting to you, is to differentiate the parenchyma of the pancreas, the ductal architecture of the pancreas, and if you are able to delineate a ductal communication.
Yes, sir.
Because if it's a chronic pseudocyst with a ductal communication, you should not be waiting for any longer period. That pseudocyst is not going to come down. Okay, that is the biggest advantage of doing a CT scan. Apart from the fact that you can know so many things about, a very important thing is exact delineation of the size of the lesion and corroborating how things are progressing. Because if it's a chronic pseudocyst, you are not going to wait. Once it is more or less localized, you are going to operate. But if it's an acute pseudocyst, you have to look at the progression, because 90% of the acute pseudocyst will disappear if you wait for 8-9 months. You should not be offering surgery at the earliest.
Yes.
And so what about wall of the cyst? Wall of the cyst is important.
Yes. Sir, wall of the cyst, sir, in CT scan, sir, it will be contrast enhancing also.
You can assess the thickness of the wall.
Thickness of the
a matured cyst wall is important, and try to find the interface, yes, between the stomach and the cyst. Yes. Because you have a good amount of interface. That means this cyst is not adherent to the stomach. Yes. These are the patients who are not suitable for endoscopic drainage or not even suitable for surgical drainage if the cyst and the stomach wall is not adherent. Yes. So that you can see better in CT scan.
The other important thing in pseudocyst, while you are doing an ultrasound, is that how can you differentiate between a pseudocyst of pancreas and a cystic neoplasm? You told it can be cystic neoplasm. How will you differentiate radiologically between the two?
So in cystic neoplasm, there will be a
Solid.
Liquid as well as solid component. There may be
Serous cyst adenoma. Let us take one by one. What will be the appearance in CT scan in serous cyst adenoma?
Sir, solid component will be seen, sir.
It is mostly solid. It is called a faint sort of honeycombing appearance with a central stellate calcification. Okay, that stellate calcification is a hallmark of a serous cyst adenoma. One. Number two, mucinous cyst adenoma. What is the hallmark?
Yeah. How do you find specifically?
See, let me explain. Now, it's a pseudocyst, means it's an unilocular cyst. Okay, most of the pseudocysts are unilocular, except if they are not infected and leading to an abscess formation. Whereas, if you look at a mucinous cyst adenoma, this is multiloculated.
Yes. Septated.
And there is a solid component in one of the cysts. There may be an eggshell crackling calcification in the walls, which suggests that this can be a malignant pseudocyst of the pancreas. Okay. Then there is a possibility of IPMN, intraductal papillary mucinous neoplasm, where you are going to find a dilated duct with or without communication, and that is called a bunch of grape appearance.
Yes.
So at least you must know of serous cyst adenoma, mucinous cyst adenoma, and that of IPMN. Okay. And if you suspect, then your whole line of treatment is going to change towards endoscopic ultrasound, guided biopsy, or going for the tumor markers. Okay. Done. So what are the investigations? You have done a good CT scan, and what was the size of the lesion in CT scan?
Can you say clinically?
Sir, 8 cross 7 centimeters.
8 cross 7 centimeter. And what other investigations? Then we will think of management.
Sir, other investigation includes MRCP, sir.
Why MRCP?
Sir, it will show the communication between the duct and cyst. Also delineate the.
How it is important to find a duct cyst communication? How it is important in management?
Sir, management will be changed, sir, if it is associated, it's associated with chronic pancreatitis.
Not always. If you have a cystal ductal communication, it may not be always chronic pancreatitis. It can be a trauma.
Yes, sir, trauma.
It can be background acute pancreatitis also.
Yes.
So finding a cyst duct communication indicative of what?
Sir,
it is unlikely to resolve, number one.
Yes, sir.
And second is you definitely need an internal drainage, not an external drainage.
Yes.
If you have a cyst duct communication, externally result in a pancreatic fistula.
Yes.
Okay, so these are a few important things. MRCP, you can safely say. Don't go to ERCP first yet, because ERCP is an invasive investigation and MRCP scores over that, just because it's a diagnostic requirement.
Yes.
Okay.
So any other investigations that you'd like to do? And
Sir, if pseudocyst, the diagnosis is not clear with the above investigation, sir, will go with endoscopic ultrasound with FNSS to differentiate between the cystic neoplasm of the pancreas and pseudocyst.
I mean, cystic neoplasm of pancreas diagnosing with FNA is not so easy. I mean, that is the Pandora's box. Can you tell us how you will diagnose a serous cyst adenoma?
Serous cyst adenoma, sir.
You aspirate and put it for
Yes.
pap staining. Okay.
Yes, there will be, pancreatic enzymes like amylase lipase will be.
No, amylase lipase is not going to come in serous cyst adenoma. Amylase lipase is going to come in case
You
of
can have some
IPMN.
tumor marker being seen
Sir,
in that.
tumor marker, Mostly, sir, CEA will be highly raised.
And
CA 99.
CA 99 and CA. And it is serous cyst adenoma is glycogen rich, so you have to go for PAS staining. Mucinous cyst adenoma, you have to test for mucin presence, and IPMN, amylase and lipase present. Okay. Now, very important, before you are planning whether the amylase lipase of this patient at present is elevated, whether the patient is having an ongoing pancreatitis or not. Okay. Anyway, sir, let us go for the management.
Yeah. Your diagnosis is correct. It's a pseudocyst of the pancreas, and you are planning for. Will you wait further, or you want to intervene at this stage?
Sir,
8 weeks down the line.
Sir, 8 weeks. Sir, usually, sir, pseudocyst resolves over 6 to 8 weeks of time, sir. And in our case, sir, it is already 8 weeks. Sir, we'll go for.
What else you look for? One is time.
Yes, sir.
Second is you've done some investigations.
Yes, sir.
How investigation can help you to decide, yes, this is a time to intervene?
Sir, sir, size of the lump, sir. Sir, it is not decreasing. It fails to decrease in size over the periods. And sir.
And anything in the wall?
Sir, wall, we have to see that wall thicknesses. By this time, the wall get matured, sir.
Yeah.
And if you can demonstrate there is ductal communication, there is no point in waiting. This is not going to subside. So it is more not previously we were taught when we were postgraduate trainees like 6 centimeters, 6 weeks. That was something. The anteroposterior diameter is more than 6 centimeters at the end of 6 weeks. And we used to do a lateral barium to find what is the exact size. But nowadays it is not exactly the size, but the trend of the swelling, whether it is progressing or not, and whether there is ductal communication or not, that decides your plan of treatment. Okay. Yes. So what is your plan of treatment in such a patient?
Sir, traditionally, sir, endoscopic, sir, drainage of the.
As a surgeon, what's your plan? And then you come to that. Once you say surgery, you come to that. As a surgeon, what is your plan?
Sir, as a surgeon, sir.
You cannot do the endotherapy.
Yes, sir. Sir, we'll do the cystogastrostomy.
So your plan is cystogastrostomy. Now people are coming with non-surgical treatment.
Yes, sir.
What's your concept?
Surgical. Sir, we'll go for the endoscopic approach. Sir, the cystogastrostomy and sir, cystoduodenostomy can be done by endoscopically. So then.
Suppose there is a good cystic and duct communication. You said one is cystogastrostomy and cystostomy, both can be done by endoscopically, but there are some limitations to that.
Yes.
Anything else which can be done endoscopically can resolution of this cyst?
Sir, we can do endoscopic dilatation or stunting.
Before that, you have to do something else. It's called as transpapillary drainage.
Transpapillary drainage.
This pseudocyst can be endoscopically drained by transpapillary drainage. What do you have to do in the papilla?
Sir, we'll do
endoscopic? Papillectomy.
Yes, sir.
Papillotomy.
Papillotomy.
Okay. I think, sir, he has done fairly well.
Yeah.
Only thing is that now such a swelling, you have to know the radiological differentials, you have to know the clinical differentials, you have to know the timing of surgery. So pseudocyst is always a case which has got multiple facets.
Yes, sir.
Okay, so you need to be careful about
any
that.
indication for percutaneous drainage for pseudocyst?
Sir, indication for percutaneous drainage, sir, if pseudocyst, sir, it is uncomplicated.
Uncomplicated?
That told you, na, if it's a true pseudocyst, that means a ductal communication.
Yes, sir, true pseudocyst
is dangerous.
Yes, sir. Sir.
You see, it's indicated number 1 in infected pseudocyst.
Yes, sir.
When you have patient is having fever, patient is having pain, tenderness, and then you find the infected pseudocyst, you can do a pancreatitis drainage.
Yes, sir.
Okay.
Sir,
What is the problem of pancreatitis drainage?
Sir, it will lead to recurrence, and sir, it
Recurrence
may
and
required repeated aspiration, sir, and also, sir, it will block the tube, sir.
so tube blockage. So it will lead to failure, number one. And number two, if you have a pancreatic ductal communication,
Yes, sir.
what is going to happen?
Sir, recurrence.
Before that, it will result in a pancreatic
Fistula, sir.
pancreatic fistula, which needs appropriate treatment.
Yes, sir.
Now, suppose this is a chronic pseudocyst
Yes.
with a ductal dilatation of 10 millimeter. You have established there is a ductal communication. What is your surgical plan?
Sir, ductal communication, sir, will do, sir.
Ductal communication plus chronic pancreatitis with ductal dilation with intertracheal calculi, pseudocyst.
Sir, we'll do, sir, lateral pancreatic jejunostomy followed by, sir, ONY cystojejunostomy.
Followed by knee. It should be same sitting.
In the same sitting.
So you have to address both the cyst and the chronic pancreatitis. If you drain only the cyst, chronic pancreatitis problem will persist.
Yes.
So this patient has to undergo a lateral pancreatic jejunostomy and cystojejunostomy in the same sitting.
Yes.
Okay, sir.
Yeah. What are the complications of pseudocyst?
Sir, complication of pseudocyst will be, sir, infection of the pseudocyst,
Yes.
rupture of the pseudocyst, sir, then hemorrhage, sir, then fistula formation, sir.
If rupture occurs into the stomach or to the duodenum, what can happen?
Sir, if it occurs in the stomach or duodenum, sir, that may lead to resolution of the
Yes.
pseudocyst.
So patient may have transient exacerbation of symptoms, but most of the time the cyst resolves by this
Decompression.
rupture. If rupture in the peritoneal cavity is going to happen,
Sir, patient may develop signs and symptoms of peritonitis,
and
sir, it may also resolve the pseudocyst.
And what else can happen? What is pancreatic ascites?
Sir, pancreatic.
What is that?
Sir,
When you say patient has got pancreatic ascites,
collection of, sir,
cyst has ruptured. If there is a ductal communication, the cyst fluid is what? Reaching?
Reaching, sir, pancreatic enzymes.
Pancreatic enzyme. So if you have a ascites which is containing amyloid rich fluid, we call that as pancreatic ascites. This cyst can rupture in the pleural cavity.
Sir, pancreatic or pleural fistula.
Yes.
So, you know,
Okay, I think yes.
very good, sir. Very good.
Basically, clinical part, and then some. You have to have a good approach. You don't jump to the next investigation. Wait for the ultrasound. See what are the information. Get an ultrasound. What are the biochemical investigation in order for this patient? What will be rational treatment? And in differential diagnosis, don't give a wild diagnosis. Keep your diagnosis confined to the possible things based on your presentation. Don't bring it. You say it is not liver swelling. So don't second diagnose, but sometimes it can be difficult. Yes, I agree that even a liver mass sometimes it's difficult to appreciate that is a liver mass. But don't bring that as second diagnosis. It can be later in the list.
Yes.
Thank you, Dr. Sarkar. Thank you very much.
Sir. Thank you, sir. Very well presented. Big hand for you. Okay.
Thank you, sir.
Thank you.
Thank you.
Thank you.